And the mood as presented is that blood transfusion is underutilized for sickle cell-related complications. Each individual will have 20 minutes to make their case, and at the end of that 20 minutes, I will interrupt if you're not finished. And the next debater will have 20 minutes, and then we'll have the floor open to the audience. All right, so without any further ado, we'll invite to the stage Dr. Ross Fasano from Emory University, and he will support the move.
So first of all, I have a question. Is anybody out there sports fans? Anybody know basketball? Anybody basketball fans?
Yeah, whichever team everyone plays for.
Okay, well, I grew up in Chicago, so I'm a huge Chicago Bulls fan. Anybody know Michael Jordan? Okay, even people around the world know that, right? Has anybody ever heard of Jerry Stackhouse?
Yeah.
Okay, usually people say no. So Jerry Stackhouse, real quick story before we get started. Jerry Stackhouse was, the similarities between Jerry Stackhouse and Michael Jordan were both UNC basketball players in college. They both played in the NBA. Jerry Stackhouse, in a summer league game, challenged Michael Jordan and played him pretty darn well. Michael Jordan didn't say anything, and then the first game in the real league, he scored 45 on him, and Jerry Stackhouse didn't even score 10. So I always think about that when I'm thinking about this. I'm going up against Graham Sargent, who's probably the equivalent of Michael Jordan, and I'm, at best, Jerry Stackhouse. So there's no beating a legend, it's just not getting embarrassed. So at that, I'll start. So I want to start with a tale of two hemoglobinopathies. So we have sickle cell disease and thalassemia here up on the board. You can see that thalassemia major and sickle cell anemia worldwide and in the U.S., you can see that sickle cell anemia is about 100 times more common, more prevalent. But when you look at the symptomatology, they're very similar. They're both hemoglobinopathies. They both have chronic hemolytic or chronic anemia, jaundice, impaired growth, can have bony abnormalities, bone pain. There's a pain syndrome, which is more common and more severe in sickle cell disease, but you can see it in thalassemia. Pulmonary complications, both in the acute and chronic setting. You can have thrombosis risk in thalassemia, which is usually related to the splenectomy. And we just heard about thrombosis problems in the venous and arterial system in sickle cell disease. Leg ulcers, retinopathy, priapism in sickle cell disease, and then iron overload from the ineffective erythropoiesis that you see more commonly in thalassemia major, but you can see that with sickle cell disease patients as well. And then pregnancy-related complications. The reason why I bring this up is when we look at the chronic transfusions, we're pretty close to 100% for thalassemia major, at least in the U.S. But when you look at sickle cell disease, less than 15% of them are receiving chronic transfusions. And so the question is that I beg to ask all of you is, why is that? Given the fact that their symptoms are very similar to disease. And this is the indications for transfusions. In the green, you can see that these are commonly indicated transfusion indications. In the red, the red font, you can see that those are in the chronic setting. In the yellow below, you can see that these are controversial transfusion settings, and all those are in the chronic setting. And what I'm going to try to argue today is that we should be expanding those based on what we know from stroke prevention and transfusions in the chronic setting. What you see here is an age-related health claims data, which actually shows trends in transfusions in the blue line, and age on the horizontal axis. And you can see that as transfusions go up in childhood, and they drop down pretty precipitously as they transition. I show this a lot in the transition talks. What you also see is in the red, there's sickle cell complications that go up at the same time transfusions are going down. It begs the question is, are transfusions protective? When you look at ER utilization and ER reliance, meaning the amount of times that people are using the ER in proportion to how many times they're coming to clinic, that goes up at the same time that the transfusions are going down. So it's a trend that you see that decreased transfusions and increased acute sickle cell related complications. Well, this was a study that came out a couple years ago by Samir Ballas up in Philadelphia, where he looked at 22 patients with sickle cell disease that were on chronic transfusions in the pediatric realm, and when they came to adult care, a proportion of those, 8 of them, didn't want to continue. And those patients, within 5 years, all of them died. And before they died, you can see that their utilization went up quite a bit. What you can see here is their vaso-occlusive crises and other sickle complications were much higher, statistically significantly higher than those that were compliant on chronic transfusions. Let's talk about stroke. So in pediatrics, you can see that sickle cell disease is a huge stroke complication rate. In comparison to normal children, it's very uncommon, 1% per year annual risk for all patients with sickle cell disease. And now with screening, you can see that we can predict that risk. So it's about 2 to 3% increased risk if you have a silent infarct, another increase about 5% if you have a conditional TCD abnormality, goes up to about 10 to 13% for an abnormal TCD, stroke 30%. You can decrease that risk by chronic transfusions, and we know that based on the landmark trials that I'm going to talk about in a minute. But also the neurocognitive outcomes. So this is a meta-analysis that was published a few years back by Mike DeBon and colleagues, and you can see that on the left, you can see the the full-scale IQ in siblings of sickle cell disease, and you can see that their IQs are about 90%, or about 90. And as you have sickle cell disease patients, it's a little bit lower. Those with silent cerebral infarcts, you're in the borderline mental retardation range. And then in the patients with strokes, you're approaching the mental retardation range as well. Unfortunately, by the age of 20, almost 40% of patients are going to have silent cerebral infarct. So 40% of our patients are going to be at the borderline neurocognitively. And what can we do about that? Well, we know in the chronic transfusion setting, these are the two studies that came out in the 90s for primary and secondary stroke prevention. On the left, you could see those patients that had strokes that received chronic transfusions that was protective. And on the right, the STOP trial, that was a Paramount trial for those patients that had abnormal TCDs, were randomized to the chronic transfusion setting that showed that it was much protective, and the STOP trial was stopped early because it was clearly superior in terms of stroke prevention. A few years later, the SIT trial came out, and this was looking at patients, again, pediatric sickle cell patients that had a silent infarct but normal TCDs, and they randomized those patients to transfusions or observation management. And you can see that those patients that were on transfusions had an improvement, statistically significant improvement in overall stroke, that's silent and overt strokes. And their conclusion was that chronic transfusion in this setting was also protective for stroke recurrence. When you look at their data for prevention of future silent cerebral infarcts versus the STOP trial, they didn't reach their endpoint for silent infarct prevention, but they did show that those patients with history of silent cerebral infarcts, that transfusions could be protective. Now I'll ask you, in the US, in our center, we've got 1,900 sickle cell patients at Children's Healthcare of Atlanta. So if 40% of them have silent cerebral infarcts, that would mean that 600 patients would be on chronic transfusions. We've got about 120. So I can tell you that that is not being standard of care, even though this trial suggests that transfusions can be quite helpful. So let's talk about ischemic stroke factors in sickle cell real quick. So we have 4 major risk factors. So you have decreased cerebral vascular reserve in sickle cell disease patients. And that's based on their hemoglobin S, we're going to talk about that, and their hemoglobin, so their anemic baseline. They also have moya-moya disease, stenosis in some of these patients. They also have episodes where there are increased oxygen demands or decreased oxygenation from acute chest syndrome, pneumonias. And they also have bouts of anemia from aplastic crisis, vaso-occlusive crisis, or even acute chest syndrome. They also have the typical risk factors as they get older as everybody else with strokes. But let's talk about their cerebral vascular reserve, because I think this is really important. There's emerging data that suggests that transfusions can really change this. So cerebral blood flow, we've known this for many years, that sickle cell disease patients have increased cerebral blood flow as a compensatory mechanism because of the anemia. And also we see that the cerebral blood flow correlates with the hemoglobin S. Also, oxygen extraction fraction is something that we were learning a little bit more about in sickle cell disease, and we know that in other diseases, increased oxygen extraction fraction predicts an increased stroke risk. Well, what about in sickle cell disease? Well, this was a study that came out by the WashU group a few years ago, where they looked at sickle cell disease patients compared to controls. They looked at using special MRI techniques, asymmetric spin echo, which basically exploits the oxygenation and deoxygenation hemoglobin states in the brain. And they were able to look at cerebral blood flow on the left and oxygen extraction on the right, and you can see that the sickle cell patients, which are the orange bars, had statistically significant increase in cerebral blood flow and oxygen extraction globally within their brain. And that correlated with the post-capillary arterial oxygenation, suggesting that they're in a state where they're doing the most they can, they're at their highest reserve. Okay? What is most impressive is the graph all the way to the right. You can see that the orange are those sickle cell patients that have the lowest post-capillary arterial oxygenation and the highest oxygen extraction fraction. So they're at their cusp of their reserve. Oops, sorry. They also they took these patients, and these are their MRI images, and they looked at the oxygen, they looked at regional oxygen extraction fraction and cerebral blood flow. And they also did heat maps of where these patients had silent cerebral infarcts. What you can see here is that where the oxygen extraction fraction was the highest and the regional cerebral blood flow was the lowest, their cerebral silent infarct or their infarct burden was the highest. You can see that on the left here on the graph here that you can see that there was an oxygen extraction threshold, whereas as the regional area of the cerebral blood flow went down, their infarcts went up. So there's a cutoff where as you get to that point, there's a threshold of oxygen extraction where they're most vulnerable. What does transfusions do? So they subsequently then took 21 sickle cell patients and they looked at these parameters, global oxygen extraction fraction and cerebral blood flow, pre and post transfusion, and they showed that both their cerebral blood flow decreased and their oxygen extraction fraction globally went down after a transfusion, suggesting that transfusions can help change the cerebral vascular reserve in these patients. What about outcomes? This is a study that just came out a month ago in Pediatric Blood and Cancer by the same group where they actually looked at cognition. And they did a battery of tests looking at executive and non-executive functioning in a cohort of age and ethnically matched controls, those sickle cell patients that are on hydroxyurea and those that are on transfusions. And they looked at these modules of executive and non-executive functioning at two different time points. And what's notable is the patients with sickle cell disease that were receiving transfusions, they looked at those pre and post transfusion and they showed that their executive functioning improved after a transfusion. So 3 days after a transfusion was much better, they performed much better than they did the 3 days before the transfusion. Suggesting that transfusions are now improving their cerebral vascular resistance, but also improving their executive functioning. So what about the rest of the body? So we know that we can change the natural history of stroke with chronic transfusions, as you can see here. But what about other disease complications? We don't have as much data on that, but we do have some suggestions and some disease outcomes. So this was a STOP follow-up data that came out almost 20 years now ago, where they looked at acute chest syndrome and vaso-occlusive crisis in those patients that were on chronic transfusions that were on the STOP trial versus those that were randomized to the observant therapy. And you can see that those patients on chronic transfusions that were compliant had decreased acute chest syndrome and decreased pain, suggesting that transfusions in the chronic setting can improve or change the outcome in other sickle cell-related complication states. Okay, last, what about pregnancy? Pregnancy is a huge problem. As a pediatrician, I consider that a big problem because not only are you affecting your patient, but also a second patient. There's two of them. And in pregnancy with sickle cell disease, we know that there's an increase in maternal mortality, there's an increase in fetal mortality, and there's an increase in pregnancy-related and sickle cell-related complications during pregnancy. What do we know about transfusions in that setting? There's been a lot of not so great data, studies out there, old and some new, mostly single institution, some prospective, lots of issues with them, but this meta-analysis is somewhat informative in the sense that there is a trend that suggests that maternal mortality and fetal mortality are both improved on those patients that receive chronic transfusions, when the mother receives some form of chronic transfusions during her pregnancy. And when you look at the prophylactic transfusions and other outcomes, so the vaso-occlusive crisis outcomes were improved. Their pulmonary complications, most of those being acute chest syndrome, were improved, and their pulmonary embolism or venous thrombosis complications were also affected in a better way. And this has led now, hopefully we'll have some answers. So there's a TAPS-2 trial from the UK that's now undergoing, I hear it started up. And this is, again, a prospective trial looking at women in their first trimester randomized to receive chronic exchange transfusions or to receive standard of care. It's a feasibility trial, but there is going to be endpoints that are looking for outcomes in maternal and fetal outcomes. So that'll be very interesting data, hopefully in a few years to look at. And then lastly, pulmonary hypertension. So when we talk about pulmonary hypertension as the leading cause of death in adults with sickle cell disease, once you have it, it dramatically changes your mortality. 50% of them are pre-capillary pulmonary hypertension, of which the drugs that have been previously determined to be somewhat helpful in other disease states of other patient populations that have pulmonary hypertension have not really panned out for sickle cell disease. So what about transfusions? There's been some case reports of it, but there's really been no data on that for any great intervention for pulmonary hypertension and sickle cell disease. We're hopeful there's a recently approved NIH trial called the SCD-CARE trial, which is going to be looking at this. It's a randomized controlled trial looking at patients with pulmonary hypertension and outcomes with randomization to receive either exchange transfusions or conservative management. So hopefully in this first session, I've at least given you some ideas that red cell transfusion therapy is underutilized in the chronic setting. It's changed the natural history of stroke, and we see that there's some data that is now emerging that, based on, we're seeing mechanistic data, that it affects the cerebral hemodynamics of sickle cell disease patients by improving their oxygen extraction fraction or their cerebral vascular reserve. And those outcomes also seem to correlate with improving executive functioning. And that maybe this will correlate to other disease outcomes in terms of sickle cell related complications that we can prevent. I'm going to leave it there. I have some other slides that I was just going to potentially use as backup in the second session. I have a feeling that based on my history of what I usually look at aluminization, iron overload, all that stuff, that Dr. Sargent's going to hit me up big time with that. So I'm just going to leave myself wide open and see what he says about that.
So Graham is going to oppose the moot that chronic transfusion is underutilized.
The proposer has made an excellent case. Can you hear me? Yes. Oh, I know I get quite enthusiastic about blood and hemoglobin. I think most of us are enthusiastic about blood and hemoglobin. Few of us would be here without it. But the question is whether it's ours or whether it's somebody else's. And here you see a blood bag, which is somebody else's. And I think nobody quarrels with blood being good stuff. But what I would argue is that you should confine your transfusion to those where there is an established benefit-risk ratio and there are no alternative therapies. All right, so let's begin to look at the areas where there's no quarrel at all, and that is maintaining oxygen delivery. And here you have acute lowering of hemoglobin in aplastic crisis and acute splenic sequestration, and more chronic things like hypersplenism and renal failure. Going through these very quickly in order, acute splenic sequestration. This is one of our first children in the cohort study, cohort 6, who at the age of 3 months came up with a spleen palpable for the first time. As you can see, it's 4 centimeters below the costal margin. Her hemoglobin had fallen by 2 grams and her reticulocytes had gone up. This is the first attack of acute splenic sequestration. We didn't understand it. It resolved spontaneously. She never had another attack, and sadly, Bettelin, this lady, died earlier this year at the age of 44 years. But many people do have recurrent attacks of acute splenic sequestration, and it turned out to be one of the major causes of death in the first year or 2 of life. Let's look at another situation, chronic hypersplenism, cohort 219. And here you see the hematology before splenectomy and 3 months after splenectomy. And you can see the hemoglobin has gone up, has doubled. Reticulocytes have halved. The platelets have gone up by a factor of 4. The red cell mass has gone up by 2.5 times, but the blood volume itself hasn't changed. So I do think people would quarrel with the use of transfusion in that sort of situation. What about aplastic crisis? Of course, most of these, as you know, are due to parvovirus B19. In Jamaica, we get epidemics of it. In one epidemic, when I looked after the sickle cell unit, we had something like 150 kids who came in an 18-month period with aplastic crisis. Dead easy to manage. You actually do a blood test immediately. They appear at the clinic. You find a hemoglobin of 3 or 4 grams. You do the reticulocytes, of course, immediately. We never do a blood test without a reticulocyte count. Reticulocyte 0 equals the aplastic crisis. Cross-match, transfuse, go home, same day. That child will eventually resolve spontaneously and will never have another attack. So here we're firmly in the field of advocating transfusion. There's another situation where we have no option, and that is the chronic renal impairment that is very common in patients with SS disease over the age of 30. Beyond 40, most of them have declining GFRs, and if you look at their histology, you will find they've lost a lot of their glomeruli. Their GFR is way down, and eventually EPO levels fall and total hemoglobin levels fall. One of the messages is how easy it is, how well they tolerate low levels of hemoglobin. In our management of patients with chronic renal failure, years ago, we used to say, well, you know, we'll give you a pint of blood and you come up when you're feeling tired again. And they'd go away for several months, and then they'd come back saying, Doc, feeling a bit droopy, you know, and you did the hemoglobin, it was 1.6 grams, so you give them a pint of blood and off they go again. It's like winding up a little clockwork mouse. Suddenly they're sort of raring. Life has changed totally. And I think one of the lessons that we learned here was how well people adjust to low levels of hemoglobin and how the patient is the best indicator of when they need to be retransfused. Let's look at the prevention of stroke. We've already heard this. We know stroke is a recurrent event, and those recurrences can be prevented to a large extent with chronic transfusion. That's fine. We accept that. Of course we do. Let's look at the primary stroke work of Bob Adams, and these are pictures. I hope these are pictures. Ah, there we are. Given me by Bob Adams. I haven't got a red spot. I shall probably blind myself. But if you look, you can see a narrowing of a major cerebral vessel, and the pictures given me by Bob Adams, transcranial Doppler, and of course, the effects of normal and abnormal velocity indicative of a stenosis, which is predictive of stroke. So we know again that chronic transfusion can actually prevent the first stroke. I'm having trouble with my button. All right. Let's look at the treatment of acute pulmonary sequestration. Exchange transfusion can be absolutely life-saving in rapidly deteriorating pulmonary function. And here you see somebody who over 3 days got a complete whiteout. And if you look at the cerebral vessel, the pulmonary vessels, you would be amazed that any circulation could actually be restored. The astonishing thing is you can see somebody who is gasping for breath, sitting up in bed with a total whiteout of both lungs. You do an exchange transfusion immediately, and 4 hours later you do another exchange transfusion. If you've got automated systems, it's much easier, of course, but these are just manual. And 24 hours later, their lungs are clear, and they're sitting up in bed eating breakfast. Clearly, that was an acutely reversible vascular problem. We're not, maybe I'm advocating transfusion. Maybe I should be on the other side. Let's see if, sorry, my button doesn't work all the time. Oh, there we are. Okay, so blood is good stuff. We are in total agreement over this, but, wrong button. But, it's not our blood, it's a foreign protein, which may raise problems related to red cell antigens, platelets, and white cells. And you can say, well, you know, we can filter these out, we can do this, we can do extensive phenotyping. At what cost? And what happens if we don't? You're well aware of the likelihood of red cell alloimmunization, published long ago, improved markedly with phenotypic typing of blood, but expensive. How can we reduce it? Well, we're probably fortunate in Jamaica because we seem to have much lower levels of this anyway, and that may to some extent by donor-recipient matching in the population here, which is less common in the US. right, what about transfusion reactions? Nothing to worry about really with non-hemolytic transfusion reactions. These are not serious. But the delayed hemolytic transfusion reaction can be extremely serious. Difficult to diagnose with a relatively high mortality, and something that we'll have to be wary of and avoid if at all possible. All right, so we've got foreign protein. We can also carry infections such as HIV, possibly parvovirus. And here we've gone to a clinic in the north of Maharashtra where two SS sisters who have chronic hypersplenism are both HIV positive secondary to transfusion. You require sophisticated and expensive facilities for collection, storage, and processing of blood. And here, you know, in Jamaica it's difficult. Our transfusion systems are relatively, I mean, they're good for a developing society, but you're often asking the mother. She has to go away and find a relative who will give a pint of blood. And if that child is on monthly transfusions, you need 12 relatives a year. And it's amazing how quickly relatives disappear when you're trying to find people to give pints of blood. So it's much easier if you have sophisticated facilities. And this is the blood collection center attached to Rio in Rio de Janeiro in Brazil. There were 22 beds, 11 pairs with a technologist between each. They explained how when the patient came in, it went on computer. The moment the technologist put the needle in, the moment it was taken out, and all this was accumulated information on the performance of each technologist. The end result was that with these pairs, we were visiting them at late one morning, and already the meter said there were nearly 400 units of blood collected. So that makes things much easier, and I think always there is going to be this dividing line between the availability in determining your decisions. So let's carry on. Finally, chronic transfusion. And here we've already talked about, we've been told about stroke, prevention of chronic transfusion. And you've got the issues, of course, with iron overload then and venous access. We had nobody who had chronic iron overload in the clinic. And that clinic looked after 5,500 patients. We had nobody with no venous access. If you look, this is somebody who's actually got a desferal pump. And they were on holiday from London in Jamaica, and they carried in a huge suitcase full of drugs that they'd been given for their 3-month Jamaican holiday. And I asked if I could take a picture of her desferal pump, showing it in operation day and night, certainly for at least 5 days a week. No pictures for patients without any veins, because we didn't have anybody who had no veins. So if anybody has indwelling catheters or has an indwelling port and can give me a photograph, I'd be most grateful to them. All right, so the question is, are these risks justified? We all accept there are risks. The question is whether we have to take these or are alternative therapies available. The North Shore of Lake Victoria, South Uganda, Aisha, chronic hypersplenism. From 2 years, her spleen increased in size. When I first saw her, she was 3.9 years. She'd had 32 admissions and 29 transfusions. The spleen was removed the following week, since when she's had no transfusions. The north of, no, not Maharashtra, this is in Gujarat, Valsad. And here you see on the left, Divyash, with the spleen that goes down into the right iliac fossa. You can see by the age of 12, he'd had 69 transfusions. Finally, they managed to remove it. It was an operation that had to be extended twice because of the size of the spleen, and over the last 10 years, he has had no transfusions. So the point of this is there are sometimes alternatives to transfusions, which I think we would argue are preferable. What about declining hemoglobin levels, common in SS disease after the age of 40? We've already talked about that. Now, the question here is transfusion at what is a steady state hemoglobin level. Hemoglobin levels vary with the genotype of sickle cell disease between patients with the same genotype and also within SS disease within different locations. Within the red cell, as you already heard today, hemoglobin S behaves as a low affinity hemoglobin. It has this huge shift, and in fact it gets virtually fully saturated in the lungs and then unloads more oxygen per gram of hemoglobin in the periphery than hemoglobin A. And that's good for oxygen delivery. It's bad for the hemoglobin molecule because it gets so desaturated. You then get the problems of polymerization. So a few messages here. Each patient has a characteristic level which should oscillate within narrow margins. If it deviates from that, there's usually a reason. Keep records of each patient's steady state level, and in extreme cases, steady state values may be as low as 4 grams or as high as 13. Here's the shift in the curve, and you can see SS patients within the hemoglobin within the red cell markedly shifted to the right. Sorry, button. All right. So a parable. Actually, before the parable, I can remember the scene shifted to the central blood bank in Valsad in South Gujarat. And the children running around absolutely fit and healthy. And I said, what are they doing here? And they say, oh, they've come for their transfusions. So I said, well, why have they got transfusions? Well, because the hemoglobins are 10, and the doctors think it should be 14 or 15. So they're all running around, lining up, waiting for their transfusion, their monthly transfusions. And this is another moral here. So let's look at a parable. If I can, there we are. Donna followed at the university hospital here from 55 to 94 when she was aged 42. Her steady state was always between 5 and 7. When I last saw her, her hemoglobin was 3.9. She had never been transfused. And you say to Donna, how are you feeling? Well, Doc, get a bit tired at the end of the day, but who doesn't? 3.9. And she then emigrated. It's immaterial that it was to the US. It does happen to be to Atlanta. And here she is, 2 years later. She's a pharmacist. She's working full-time, bit tired at the end of the day. Decides she should have a pap smear. So she goes to her primary care physician, and he says, oh, Donna, you've got sickle cell disease, don't you? And she says, yes. So he said, we better check your hemoglobin too then. And he did it. 3.8. 0.1 of a gram different from 2 years earlier in Jamaica. And she gets a phone call that says she has to go immediately to accident emergency for admission. And she does. She was given 2 units against her will, and that's clearly stated in the docket. I was an expert witness for this. And the docket was very thick, and clearly it said, we do not want to be transfused, and they would not accept her denial. They gave her 2 units, and she went to 4.9. They then gave her 4 more units, took her to 11. Within 24 hours, she had now received 6 units within 24 hours. You can see what happened to her hematocrit. You can see what happened to her blood pressure. 9 hours later, severe headaches. 72 hours later, unconscious. 2 weeks later, they switched off the life support. And the moral here was, of course, they had actually treated the hemoglobin level rather than the patient. Sorry, wrong button. All right, the diagnosis at autopsy was an intraventricular hemorrhage. And at the trial, the jury awarded $11.5 million to the family because they had treated the hemoglobin level rather than the patient. Time for a commercial break. Now here, as a special conference price for $10 US, nice, clean, crisp notes are obtainable from Mrs. Sargent Beryl sitting over there. So please, the proceeds from this will all go to benefit sickle cell patients, I hasten to add. So you have the guide for sickle cell disease. You also have as a special, sorry, wrong button again, a set of 6 posters on card, 24 inches by 16, very popular, full color, and $10 for the whole set. We have 6 sets, so the first 6 people bearing a $10 bill will get those posters. End of commercial break. So summary of agreements. Top-up transfusions, acute ASS, aplastic crisis, the observation period of chronic hypersplenism, because we usually monitor them with transfusion for about 6 months, but during which time there may be a spontaneous resolution. But after that, it becomes increasingly unlikely. And of course, with chronic renal failure. Diluting hemoglobin S cells, we talked about the prevention of primary or secondary stroke, and the treatment of acute pulmonary sequestration. No one's going to argue about those things. I'm fully behind the proposer. Wrong button again. All right, but let's look at the areas of debate. Pregnancy. The book was first published by Mabel Koshy in 1988, which showed that chronic transfusion given during pregnancy improved the maternal outcome, but the object was to improve fetal outcome. And there was no change in fetal outcome. And a review 30 years later, published last year, reached exactly the same conclusions, that there was no convincing evidence that transfusion improved fetal outcome. Preoperative, there's no compelling evidence that this reduces the morbidity or the mortality. And then specific complications, transfusion intervention proposed for many things, including priapism, hip necrosis, leg ulcers. There is no good evidence for supporting these. So transfusion at steady state levels, be wary. Be wary of the parable. There's nothing magic about 10 grams of hemoglobin. If I meet a surgeon, and we're fortunate with our surgeons and anaesthetists in Jamaica who are very well informed about sickle cell disease, but if I meet somebody who says they're not going to do anything until the patient has a hemoglobin of 10 grams, I will give them a piece of paper that says, hemoglobin 10 grams, and they're happy. It doesn't make sense. So, in summary, you can see on the left increasing agreement or disagreement. And we've summarized all of this. So at the top, everybody agrees that acute lowering hemoglobin, you transfuse. A whole lot in the middle where there is no real convincing evidence. And then at the bottom, transfusion of the steady state. Be very wary of the experience that a patient encountered in Atlanta. Thank you very much.
Are there any positions that's complementary or against the point taken? Any points of disagreement? So I will start as a chair. I noticed that in both presenters, nobody mentioned money. I will start with you, Dr. Fasano. What's the average cost to treat somebody by chronic transfusion in US dollars term per year, on average?
Well, I can say per unit.
Yeah.
So per unit, it's can range based on how many antigens you want to match between $350 to $400, $350 to $500 per unit. So if they're getting if for an adult it's getting 2 units every month, that's going to be $600 to $800 to $900 per month. Now, extrapolating Dr. Ware's hydroxyurea data, I think what I heard was about $1 per day for 500 milligrams of hydroxyurea. So an adult being 2,000 milligrams per day, that probably is about $120 per month if they're compliant. And then if you were to take, let's take, I don't know what the transplant data is, but let's take gene therapy because that's the hot one. So how much do you guys think that the gene therapy price of that product is going to be, just the product? Close. It's actually, if it's going to be what the CAR T-based therapy is going to be equivalent to, it's about CMS approved CAR T to be about $480,000 just for the product alone. So, cost is an issue, absolutely. And if hydroxyurea was equivalent to transfusions in the chronic setting for prevention of certain things, absolutely. So are there scenarios where we'd want to not be on chronic transfusions? Absolutely. So those scenarios would be Dr. Ware's Twitch data, patients with an abnormal TCD with minimal vasculopathy, somebody that could be transitioned off of transfusions. Hydroxyurea seems to be non-inferior, cheaper, absolutely. Would you want to take somebody that's had a stroke off of transfusions hydroxyurea based on Dr. Ware's data, the switch data? Probably not. So the cost is definitely an issue, but the outcome to me is more important.
Okay, but in doing the cost, you also didn't tell about the cost of, so Graham mentioned the issues of some of the complications from your chronic transfusion. And am I taking sides? Yes, that's good. So the other part about it is, in terms, and you said you had those slides, the cost of treating the iron overload and the complications of chronic transfusion.
So I don't have the costs broken out for the whole therapy. But chronic transfusion therapy is expensive, and the things that bring up the cost are, one, the units. The chelation therapy is very expensive in this country. It's more convenient than Desferal in the old days, but it's more expensive because it's orally available now and it's expensive. I think the quotes that people have used is about $70,000 per year for an adult that's on X-Jade or Jadenu. And that's not to take into fact the iron overload monitoring, MRIs, and then the visits every month. So transfusion is definitely in the chronic setting is going to be more expensive. However, if you're decreasing the amount of admissions to the hospital for pain, where does that wear out? Where does that pan out for cost effectiveness? I'm not aware of any cost effectiveness analysis of chronic transfusions versus not that have been published. But it is more expensive than hydroxyurea, for instance. Absolutely.
All right, and so back to you, Graham. You mentioned in your discussion that one of the areas for which you think that there's no real convincing evidence for is preoperative transfusion. Yes? Yes. Okay, great. No. This is my stat. That's my preference to make sure I got that right. Right. But I thought that the study by Jo Howard and her group about a few years back Joe Howard?
Oh, Howard.
Yes.
Howard, right.
Yes.
Yes.
The TIP study?
Yes.
Right. Would have suggested that it would have been better for individuals to have preoperative transfusion.
As opposed to?
No transfusion at all.
Oh, I didn't realize that was the alternative. Now, I think the alternative is all right. Do you need to have the patient transfused to induce anesthesia? Most anaesthetists say no. There is absolutely no problem. So what will happen here, it's a question of whether, of adjustment to the hemoglobin levels. Now, here where we have excellent surgeons and anaesthetists familiar with sickle cell disease, they will actually do a total hip replacement at a steady state level, which may be 6 or 7 grams. Now, they clearly have 4 units cross-matched, ready to replace, because it's a bloodbath anyway. So they're going to be transfused. So that's why I query whether it's no transfusion. It's never no transfusion. It's whether you actually have to transfuse before induction or before surgery. And the experience from our, I'm quoting now Professor Homey and the department there, was that that didn't seem to make any difference at all. They just have to be in a good state, they have to be well hydrated, and they have to obviously have blood matched to replace that lost at surgery.
Okay, and so in leading away from that, Dr. Fasano presented some interesting data to suggest that chronic transfusion improved IQ, or cognitive function. And so within that context, you mentioned the concept of steady state. And we all agree that as individuals age, that steady state numbers will tend to fall. Would you subscribe to the view that one quality measure in a person's life that we could aim towards with the chronic transfusion thing is an improvement of their cognitive function, which in theory should lead to a better economic outcome in terms of work?
What's the question?
So, so wouldn't that be a justification for us engaging in the chronic transfusion program?
So you want to put everybody on transfusion in the hope they will improve their IQ, is that right? Well.
Already.
No, I'm not sure that that's entirely realistic. It's interesting, actually, when you're talking about IQ, because there is quite a lot of data suggesting that the IQ levels of SS patients is lower than matched AA controls. And you can try and rationalize this in many ways. They're in and out of hospital, possibly. They're missing schooling, they're missing formal education. But in the cohort study, we had all of that. We had actually their morbidity generally. We had whether they'd been out of hospital. We had their school attendance records. And the truth was that, in fact, it didn't account for the genotype difference in IQ that we had in the cohort study. And in the cohort study, we're talking about SS children and AA controls of the same gender, born on the same day, usually minutes before and minutes after the index case with SS disease. And we did a lot of analyses, and we confirmed that the IQ was lower in SS disease than in the AA controls. But we factored all of these things in it, including hemoglobin, and it didn't account for the genotype-related difference. And then we looked at growth. And the astonishing thing was, the people with higher height velocities in the first year of life, with all the inaccuracies of determining height velocity at that age, had higher IQs later. And the question then was whether, in fact, they were actually suboptimally nourished, which impaired both growth and cognitive function. And I think this is the way in which we should try and develop our understanding of the disease, rather than just say, here's some blood, give it to them. You know, blood has great emotive impact. For the patient, they feel better. For the doctor, they feel even better giving blood. They like to do things.
Fenella and Julie.
Okay, just on the subject of brain and the stroke, the question of the IQ, first of all, Anna, you presented Anna Hood's very nice work from WashU on executive function, so thank you very much for presenting that. However, in the supplement to the SCiF trial are buried the results of the full-scale IQ, and there was absolutely no change over 3 years of transfusions in the silent infarct children transfused for that period of time compared with control. So I think that the hope that you would dramatically improve IQ by transfusing for life is false, and I'm awaiting somebody to tell me what the data are on hydroxyurea. Secondly, apart from a few patients in Russell's early paper from about 1986, there's been very little data to show that vasculopathy gets better on transfusion. And so what you're really doing with patients with stroke is keeping the oxygen delivery up, reducing the oxygen extraction fraction, as what Fasano said, but you're not actually solving the primary problem. And I think one of the problems with transfusion, which of course was introduced from Carr's very nice cohort study and the work of William and Sano many years ago, all very good data, but actually all cohort-based, and it has stopped people thinking about whether we could do something to heal the vessel. And the third thing is that, as Monica Halbert's data showed, and we put some UK patients into that study from the Neuroheme Consortium, there are still quite a lot of recurrent strokes and silent infarct and progression of vasculopathy despite chronic transfusion for stroke. So we have not completely solved the problem, and we do need to really start thinking more creatively about what we're going to do about vasculopathy.
Here. Julie? All right, you could use mine. Don't worry too much.
Oh, I think, okay. So the experience that we have in Tanzania is that the top cause, if you remove infection, of death is anemia, severe anemia. 4% of the patients who come to the clinic in steady state have severe anemia. This is a hemoglobin of less than 5. And I think this is what Graham has described in the population that you see in Jamaica, where there is patients have compensated or feel that they can live with a hemoglobin of less than 5. The problem is that during hospitalization, we found that 20% of patients had a hemoglobin of less than 5. And when we looked at the survival, we found that the level of hemoglobin at steady state was an independent predictor of mortality. So I think we have to take into account that when we have a population with a hemoglobin of less than 5 at steady state, when they do have an acute episode, they are at an increased risk of mortality. And so the evidence, I don't think there's enough evidence to say whether and how we should manage patients who have hemoglobin of less than 5. And this is assuming that all the reversible factors have been managed, whether it's the iron deficiency, etc. But these are individuals with sickle cell disease who had steady state of a hemoglobin of less than 5. So I'm a little bit wary because we don't really have enough evidence to say how we should manage them, and to say that they should receive chronic transfusion or they should not. I think it's something that we should say that we require evidence to do that before making decisions as to whether we should or should not. I don't know whether that makes sense, and maybe you could comment on what your experience is like in India, because in this instance, you did mention in your slide that severe anemia is a real cause of mortality in the patients that we look after.
Yeah, but it is, I think even we have steady state of a level of hemoglobin, And my patients, I don't see patients, most of them are below 7 grams hemoglobin. But it is not the hemoglobin level alone, how acutely the level has fallen. When we look at the mortality, severe anemia, if it is compensated, I don't think the risk of death is much, but if it is acute, then yes, it is one of the risk factors.
And so I'd just like you to give a round of applause to our two contestants this evening, our two debaters.